to introduce our first keynote speaker, who is Dr. Lisa Kachnic. And she is the chair of radiation oncology at Columbia University Medical Center, as well as at the Herbert Irving Comprehensive Cancer Center, and joined there in the fall of 2019, so not quite 2 years ago. Previously, she had been the chair of radiation oncology at Vanderbilt. When I was going through her CV, it made me feel about that big, in spite of the fact that I'm probably a few years her senior, a lot of years her senior in respect to her. But she has done so much in the field of radiation oncology, as well as in the field of oncology as it applies to gastrointestinal cancers. And I didn't even notice this till I was looking at the bio that I had an opportunity to look at until earlier today. And I think you've also served major national roles on the American College of Radiology. Is that correct? Where you'd served as president, and now in the additional kind of post-presidency responsibilities of taking on those kind of national leadership positions. And she has been very active in NRG oncology, as well as with the NCI Community Research Program, and co-chair of the NCORP Cancer Control and Prevention Division. At SWOG, she serves on the anorectal committee and serves as co-chairperson. And so I could spend all of her appointed time for talking, saying about all things that we've done. We are very fortunate to have Dr. Kachnic here this morning. And so let me introduce Dr. Kachnic as she is going to give her keynote address on are we moving the field forward in the management of anal cancer, anal canal cancer. Dr. Kachnic, thank you so much for joining us.
Thank you so much, Dr. Ink. That was a very, very kind introduction. And I want to thank you and Dr. Lynn and the organizing committee for inviting me here today. It's sad that I can't be there in person and we're having yet another meeting virtual, but I'm still excited to be part of what looks like a great morning for me as well to learn things in anal cancer. Here are my disclosures. So in terms of learning objectives today, I'm going to first review the cancer biology for anal canal cancer very briefly. I'm then going to spend a lot of time reviewing the evidence-based rationale for definitive chemoradiation in localized disease. I'll discuss ongoing and future trials, and then we'll end with a case looking at contemporary radiation oncology management. So while this was at some point considered a rare disease, by virtue of it increasing every year due to what we now know is really an HPV-driven disease, I think it's kind of falling out of the rare cancers, which is usually about 7,000 per the NCI top-off. In 2021, we had about 9,000 cases estimated, and 3/4 of these are women diagnosed with this disease. With about 1,400 estimated deaths. And if you look on the right, you can really see that deaths kind of have remained the same throughout the last 3 decades while our cases continue to increase. Hopefully, in the next few decades, as more children and tweens get vaccinated, we'll see a sort of decrease in incidence, or at least I'm hoping that I will see that in my lifetime. And then just to be complete, while we know this is really an HPV-driven disease, we do have a cohort of patients with immunosuppression I see a lot of cardiac and renal transplants here at Columbia with anal cancer, and still a few patients with uncontrolled HIV. So as a very basic reminder, HPV is a family of greater than 200 double-stranded DNA viruses. They infect mucosal and cutaneous surfaces. The low-risk HPVs, 6 and 11, are responsible for greater than 90% of the genital warts, respiratory papillomas, and many low-grade lesions. And then the high-risk HPVs, namely 16 and 18, are linked to the cancers and to the high-grade precancerous lesions. Now, just for a little bit of a review, this is the HPV genome, and we talked about it being a circular double-stranded DNA, where upon infection, you induce transcription of several viral proteins, and they're broken up into early and late. And for the early proteins, the most important ones are 6 and 7, because these are the oncogenes, and they hijack the cell cycle and lead to genetic instability due to the inactivation of the P53 and the retinoblastoma proteins. And then physiologically, the retinoblastoma protein inhibits cyclin-dependent kinase inhibitor, P16, and we now know that inactivation of the retinoblastoma leads to upregulation of the P16, which has really been our surrogate marker for this disease. So we've also recently found out a bit about the mutation profiling, and this really came through data sets looking at immuno-oncology for metastatic disease. And interesting, like cervical and like squamous cell of the oropharyngeal cancers, PIK3CA gene is the most commonly mutated one in anal cancer as well. And then for HPV negative anal cancer, which is rare, it's the P53 mutation for that. They haven't seen really KRAS, NRAS, or BRAF mutations. I will say though, in my prior lab career, before my Vanderbilt and Columbia gigs, there were some cohorts of Fanconi anemia mutations, which is with the BRCA for homologous repair. Now, what about HPV as a prognostic biomarker? So this is retrospective data, but a large series, and they looked at anal cancers, and HPV positivity was in about 90% of cases. If you look at HPV positive cases, they had significantly better survival compared to the much less HPV negative. And the figures here on the right are those of the P16 positive group, where both overall survival and disease-free survival were significantly longer compared with P16 negative. When you looked at regression analysis, P16 still remained an independent prognostic factor for overall survival. Now, I know for all of GI cancers, with our work through the NCI cooperative groups, circulating tumor DNA is all the rage right now, and we're trying to collect it sort of pre, during, and post-treatment on all of our studies. Even here at Columbia, the medical oncologists are starting to look at it in our rectal cancer patients and using it a little bit like CEA in terms of maybe doing earlier restaging studies if they convert from negative to positive. But in any case, what about that as a prognostic biomarker for anal cancer? Small, tiny series of about 30 patients. They used a 16 and 18 E7 multiplex PCR to look at ctDNA. After patients got chemoradiation, residual HPV ctDNA was associated with patient outcome. 3 patients that had residual, again, remembering this is a small data set, but 3 patients that had it experienced a very rapid metastatic relapse between 1 and 4 months after completion of chemoradiation. And among the 15 that were ctDNA negative, only 1 experienced local relapse. So interesting data I think on our next randomized trials that we're developing now for anal cancer, we will collect this to learn more. Now, what about the typical tumor and clinical prognostic factors? I take this from one of the larger randomized trials, which we'll review in a bit. And if you are male, if you have lymph node positivity, or if you're a large tumor size, those patients have a notable decrease in disease-free survival and time to colostomy. And if we look at just SEER-based survival rates according to stage, for localized cancers, it's about 80% 5-year survival, regional 65, and distance a little over 30%. Now, I do have someone saying they can't see the slide clear. I hope everyone can. If not, just send me another chat to let me know. It looks clear to me, although this one maybe not as good as the others, but let me know. So I'm going to now go into current management approaches, and this is where we get into the evidence-based literature. So for the NCCN guidelines, I have to say for localized disease, it's not as exciting. It's really been the same over many years, but you'll hear from Dr. Tenner next that we have made significant inroads for metastatic cancer, where we now have a preferred regimen and secondary subsequent therapies. So now to the overview for localized cancer. Just to be complete, if this is an anal margin, so a skin cancer outside of the verge, it's treated with surgical excision or radiation alone. If you find adenocarcinoma and not squamous in the anal canal, you treat it like rectal cancer. And now for what we're going to talk about, squamous cell of the anal canal. If you do have a T1 tumor, not a whole lot of data, just again, small series. It shows that you can really treat with local excision, radiation alone, or sort of a de-escalated dose of chemoradiation. If you have T2 and above, we show that chemoradiation with sphincter preserving curative intent seems to do a pretty good job. And then for salvage now, we use an APR for local recurrence. So what about surgery alone? You can see just by the figure on my slide, a really old data set from the 1980s. And prior to the advent of chemoradiation, an APR, abdominoperineal resection, was really the only treatment option for these patients. And even after taking everything out, recurrence rates were still about 40 to 70%, depending upon stage. A surgeon, Dr. Nigro from Wayne State, actually had the first evidence that chemoradiation could be used for this disease. This was way before the times of IRBs. It was started in the late 70s. And he took his patients that had anal cancer and said, okay, I'm going to put trimodality therapy for them. Do chemoradiation and then a planned APR. And what he used was, back in those days, those big boxy radiation fields, only 30 gray, really treating all the same nodes we treat today, and gave 5-FU the same way, and then a single dose of mitomycin bolus of 15 milligrams per meter squared. And then in his planned APR found that the majority of patients had a pathologic complete response. So then took another series of patients and just did chemoradiation and found that overall survival and colostomy-free survival was as good as the previous APR series. And that really led to several randomized trials looking at what was the optimal radiation or chemoradiation for this disease. There's 2 big trials from the UK, one quite big from the UK, looking at, do you need the chemotherapy? And then RTOG asked the question later on, after those 2 were coming out, well, do you need the mitomycin? And I'm going to go present Act 1, this large series from the UK. There were almost 600 patients that were clinically staged. Again, remember that these were studies that started, these series were in the later 80s. and they were randomized to radiation alone or chemoradiation with 5-FU and a single bolus of mitomycin day 1, and that's how they give it in the UK, still a single bolus, but at a higher dose. And if patients had a response 6 weeks after completion of chemoradiation, they got an additional radiation boost. Their primary endpoint was 3-year local failure, and at 42 months, they had a 46% reduction in local failure risk with the addition of chemotherapy. And if you look at their data set after many years, there still was, even after 12 years, a 25% reduction in local regional relapse with chemotherapy. And this is the theme. It hasn't really been a survival advantage. It's been really more a colostomy reduction, local recurrence advantage. Now, RTOG asked the question in a RTOG-led intergroup trial, do you need the mitomycin? Because that was really the stinker, if you had to pick out of the treatment in terms of the toxicity, notably the hematologic nadir from it. There were about 300 patients, also clinically staged, that were randomized to radiation and 5-FU, the 1,000 sort of over 4 days bolus, weeks 1 and 5, versus radiation 5-FU and mito. Now, in the States, we give mito bolus day 1 and day 25, first day of the 5th week, 10 milligrams per meter squared, typically these days. In this case, you've got an additional chemoradiation kind of boost if you had persistent disease 4 to 6 weeks later. It's funny, I recently went back to the original paper and there's no primary endpoint. But remember, these are the times kind of when we were just starting to do IRBs and better statistically planned trials. But despite having no primary statistically powered endpoint, they did show that time to colostomy and disease-free survival at 4 years significantly favored the addition of mitomycin. So less colostomies, more survival if you included the mitomycin. So a similar story with the chemo, but now we know that you need both 5-FU and a DNA cross-linker. What are some of the toxicities of this treatment? So acute, we know there's anorectal dysfunction, but it's not graded well by the physician nor by patients. We know for GU, there's an element of frequency, sometimes cystitis and dysuria. We do see desquamation of the skin, and this is actually quite high. I mentioned the hematologic morbidity, and in those 2 series, there were even some neutropenic septic deaths. And then chronically, where we could use some patient-reported outcomes data, anal incontinence and fibrosis, especially in the pre-IMRT era, vaginal stenosis, small bowel obstruction, hip fracture, more common in postmenopausal women, and definitely sexual dysfunction, but really no good studies addressing that. What are some of the strategies to maintain outcomes and decrease morbidity? Well, I'm going to talk to RTOG 9811, which substituted mitomycin, and then technical improvements in radiation with IMRT, RTOG 0529. But Dr. Lin is going to give his exciting results on the radioprotector BMX001 this morning. So first, RTOG 9811. I have to say I was on RTOG, but was not part of the development of this because I might have actually developed this randomization a little bit differently. So the standard arm was what we had done for decades after that NIGRO trial, which was give radiation to a dose of about 54 gray for T2s and closing towards 60 gray for T3, 4s or N-positive disease. And then I mentioned already the mitomycin and 5-FU weeks 1 and 5. The experimental arm was replacing the mitomycin with a different DNA cross-linker, platinum, but also an inroads of 2 cycles of 5-FU and platinum. And they had done that because it was the pilot data that they used to develop the experimental arm of this trial. But you can already see it's kind of like apples and oranges and would have been better served with a 2x2 randomized design. In any case, the primary endpoint was 5-year disease-free survival improvement with the platinum. Now I'm going to not go to the primary paper, but I'm going to go with a secondary publication that shows if you waited to 5 years, you actually had inferior disease-free survival and overall survival with the addition of platinum. They really were hoping that platinum would reduce the overall toxicity, but as you can see here, the worst overall toxicity was also the same, whether you gave the mito or the platinum. And really all you did was replace the hematologic and skin toxicity with some GI. The rates of long-term side effects were also the same. So in conclusion, not really a direct comparison between arms, but I think we can say induction chemo was of no additional benefit, but we can't really determine if platinum was a good substitute for the mitomycin due to the design. And after this trial, 5-FU and mitomycin with radiation was continued as a standard of care and still is to this day in the States. We do have good toxicity data to look at from this trial with, again, still that boxy technique, although we got a little bit fancier sometimes, at least for the a boost after the big APPA fields. We did see that heme grade 3 and 4 toxicity was about 60%, derm about 50, GI about 35, and GU actually was pretty good. So then we decided right after all of the IMRT intensity modulated radiation data came out for head and neck, and for the non-RADONC folks, this is where instead of these boxy fields, we can actually kind of almost paint the radiation dose to where we want it to go using these collimators that are moving in and out on our kind of treatment head where the beam, the radiation beam comes out. And so here we can kind of limit dose to normal tissues and really treat the elective lymph nodes and the tumor to the dose we want. So we decided after head and neck IMRT data came out showing that it was really good in reduction of acute toxicity for head and neck cancer that we do it for anal cancer. And so we just had a single phase 2 study in RTOG, hoping that with IMRT, we could also reduce toxicities. We picked based on what we saw were dosimetric savings in patients we planned with IMRT in the clinic getting ready for this trial, and actually picked a combination GI, GU, grade 2 and higher toxicity. Although you'll see the data that didn't pan out because GI wasn't really a problem in these patients, but we did still get some very good acute toxicity sparing. And as I mentioned, that was the primary endpoint. So trying to think about that cartoon boxy picture of radiation I showed you for RTOG 9811, on this trial, we also gave different doses for different stages of disease. For T2N0, we gave a dose of 50.4 gray to the anal primary, anal canal, and a margin, which we call a planning tumor volume. And then we gave our lymph nodes, in this case, they were N0, and the lymph node groups we go after are mesorectum, the inguinal, the external and internal iliac, and the presacral. They all got a dose of 4,200, which is sort of lower than the normal 180s we give for the radiation oncologist. But we wanted to do IMRT in sort of a single plan because it's a little more time resource intensive for the department. And that's what we came up with using our sort of radiobiology biologic equivalent dose calculations. And then for higher dose disease, we gave 54 to the primary, and for very large positive nodes, and then 50.4 for smaller positive nodes, and 45 to the sort of elective nodal volume. We had 52 valuable patients. The nice thing is, for those of you that are radiation oncologists and used to treat with the big boxy treatments, you'd have skin desquamation all on the front, all on the back, all weepy. And even if you didn't have hematologic natoring that would necessitate a break, you often just had to give a break because the patients were just sort of leaking desquamation all over the place and in pain. With IMRT, we don't really see that much anymore. We just see perianal and sometimes after that 5th week of chemo, a little groin desquamation. So these patients really didn't have to have a break. We did, though, actually check all of these volumes and physics plans before the patients actually got treated. And it was a bit of an education in that over 80% of these plans needed a quick revision, but we were immediate to review them, so I don't think we really held up the patients for their treatment. We did see an improvement in acute toxicity. The 9811 we used as a historical comparison, that mitomycin arm, again, that sort of cartoon boxy radiation. And then the purple here was this IMRT trial. We did see a sparing in grade 3 and higher GI-GU. It was all GI. If we pulled GI out, it would be much more significant. And then we did see a sparing in skin and heme. We just published the long-term outcomes. We have about over 7 years of follow-ups. And even though the 52 patients on the IMRT trial had more advanced disease, we were happy to find out that the disease-free survival was pretty much spot on. So no significant difference. In fact, it was a little bit better. And we also noted that the colostomies that were performed for local failure on 0529, or I should say colostomies that were performed on 0529 were just for local failures, whereas on 9811, there were quite a few that were done because of the toxicity from the chemoradiation. And then I did mention for the radiation oncologists that are on that we used a sort of lower dose 150 centigrade per day for our elective nodal coverage. And the good thing to note, there weren't any nodal failures unless you had a primary or a distant MET. So that was also good to know that that was a okay enough dose on this trial. And then we showed all our late sexual function results. It's hard to compare to 9811 because they use different late sexual function scoring systems. So I'm just showing you the sexual function one, but I have to say there were very few grade 3 and above events. And if you look just at sexual function, where we know vaginal stenosis especially is an issue, good to know that we didn't see any grade 3 and above. There was only one grade 3 and above ED and 2 irregular menses. So in conclusion, small phase 2 study, but it just like in head and neck, it really established IMRT as the radiation treatment to move forward with from this trial. So despite what I've showed you, we still have an opportunity for improvement in more locally advanced disease. Look at the 5-year disease-free survival just from RTOG 9811 per stage. So we can still do better. So what are some of these strategies that we'll briefly go through? We have adjuvant chemotherapy. We know giving it before was no good, but what about after the chemoradiation? Increased radiation dose, EGFR inhibition, just like for head and neck. And what about adjuvant immune modulation? So first, the additional chemo question. This was the Act 2 study from the UK. I showed you the Act 1 earlier. And this was a large 2x2 design, which asked 2 questions. The first one, what about that substitution of platinum instead of mitomycin? And the second was out back 5-FU and platinum. Their primary endpoint for this one was an increase in clinical complete response at 6 months in favor of the platinum. And for this one, it was a progression-free survival decrease with maintenance 5FU and platinum. And they had a median follow-up of 5 years. Unfortunately, the exact same results were seen for both of those questions in each of those arms. So the 6-month clinical complete response spot on, as was progression-free survival for the 2 arms. So negative results. So in conclusion, platinum appears no more effective, but this was not powered for non-inferiority, so you really can't say anything. You can say, because it was powered for this, maintenance chemotherapy was not effective. What this did tell us, though, so it did contribute to our management, was that the tumor continues to respond even after 3 months. So prior to this study, really 3 months was a sort of check-in to say, okay, do we need to start thinking about APR if there's still tumor? But we found from this study that if things are going in the positive direction at 3 months, hold on to 6 months because they still respond. Next is the Accord 03 trial, also from the UK. And this was also a 2x2 design. Unfortunately, had that sort of bad in-run like 9811. But the second randomization looked at a higher radiation dose. And the primary endpoint for both of these questions was an improvement in colostomy-free survival for the platinum and for the higher radiation dose. This also was a negative trial, although I would say if you gave the initial chemo and the higher radiation dose, numbers trended slightly higher, but it was not significant. And then the UK now has the ACT-5 study ongoing. And what that is using sort of the same IMRT, very close to doses we used on our United States RTOG trial, is looking to see if increasing the radiation dose with IMRT gives you improvement in 3-year local regional control. And that's ongoing. I did want to talk about the use of cetuximab, again, playing off a head and neck in anal cancer. These were 2 single phase 2 studies, one in HIV patients from the AIDS Consortium and one in immunocompetent patients from ECOG. They both had 3-year local regional failure primary endpoints, and both of these did not meet the primary endpoints. I will say that they did use 5FU and platinum, and then the results of 9811 came out and they switched to a mitomycin approach, but they still weren't effective. Now, what about immunocheckpoint blockade? Just again, like we're seeing for every other solid tumor and also for squamous cell of the head and neck. Well, Dr. Tenner is going to talk about that, but I just wanted to mention that and the phase 2 NEVO trial as being showing responses in second-line treatment. I just wanted to mention all this because there was just a completed trial for local disease, and that's the ECOG Akron 2165 trial, which basically, for the most locally advanced, you got chemoradiation and you can get randomized to adjuvant NEVO or observation. And this trial literally just finished accrual this week, and we probably won't have a readout for it for at least 2 years, depending on the events. The nice thing about anal cancer for patients is typically if you're going to recur, you do within about 2 years. So we're trying to develop the next phase 3. One thing we're thinking about is moving immunotherapy sort of more upfront. Again, basing it on some nice head and neck data that was presented at last year's ASCO, which was a combination of platinum and Taxol and a double checkpoint inhibition. And so we're thinking about the same thing for SWOG, kind of doing a carbo Taxol, which is really the new standard for metastatic disease in anal with a double immuno checkpoint versus just IO, and then chemoradiation, maybe even with IO. We have some pharma support, and we're trying to move this along in SWOG. I didn't want to mention, what about early stage anal cancer and potentially de-escalation from those doses I showed you for T2 and 0 disease. Now in the UK, they have Act 3. They're looking at if you had a wide local excision for T1 and 0, you observe, versus a close margin giving a little bit of radiation alone. They have Act 4 for the early stage disease, and that's giving a de-escalated radiation dose from what we typically give here with IMRT, which is 50.4. And then I mentioned the more advanced disease already. In the States, they sort of played off of that UK de-escalation study for T1s and T2 and 0s, and that's enrolling. It just started a couple months ago, and basically giving similar doses as the UK for T2 and even a lesser dose for T1 disease. All right, so now here's our management and the case, and I'm looking like I'm actually doing pretty well for time, which I'm excited about. So this is a case I had recently. It's a 42-year-old female who presented with rectal pressure, some bleeding, and a left groin node. She had decreased stool caliber, urgency, and a single episode of fecal incontinence. She systemically was okay. No real past medical history, but had a bit of a family history with pancreas, multiple myeloma, and HCC. And she's a former smoker and a social alcohol user. So just a typical patient evaluation that I would endorse would be sexual history, HPV, HIV risk, a good exam for all of the groin-bearing regions, and DRE, including anal tone. For females, I always want to make sure there's nothing else HPV going on. So either yourself or get them evaluated by a good gynec colleague. And then a fertility and endocrine discussion depending on stage. Depending on age. And then for males, similarly, a full GU exam. And you can think of an anal pap if they're at high risk. And then fertility and erectile dysfunction discussion. Typical labs, if they haven't had an HIV, I would just grab it for completion's sake, especially if it's an HPV negative tumor. For anal, you don't have to do a full colonoscopy, but we need to evaluate the anal canal and lower rectum. So whether it's an anal rectal scope from the surgeon, a sigmoidoscopy, or colonoscopy is all fine. And then when you do the biopsy, don't forget to have path run a P16. And then for systemic staging, an abdominal pelvic CT scan and chest X-ray or chest CT. And now PET for the last almost decade, or at least 5 years, has been approved as a baseline screening method. I have to say on CT, they're so good these days. I can see the morphology of the lymph node, and that between the PET uptake, I don't really get FNAs of suspicious nodes any longer, but you can. So on my exam for this patient and on the surgeon's EUA, she was found to have a mass starting 4 cm from the anal verge, so kind of really high up in the canal around the dentate line from 4 to 11 o'clock. She was in the prone position for my exam. Good anal tone, no blood, nothing on the skin of the anal margin outside of the verge. My bimanual exam and GYN were negative, but I could feel the tumor abutting the vagina. She had a really large left inguinal node, but also surprisingly a right inguinal node on my exam. And then again, just sort of what I do on VRE, distance from the verge, sup extent, my clock location, whether it was circumferential, anal involvement, skin involvement, anal tone. And this is all good because in follow-up, I always refer back to my initial exam to look at the response, because when you see lots of patients, obviously you're not going to remember. So the more you can detail in your note, the better. And again, I send all my women for updated PAPs and also for them to evaluate to the GYN for them to evaluate, as well as discussion of fertility and endocrine function. So the workup continued. Since this was sort of a high anal canal, they did a colonoscopy, nothing more to show, but she did have another small negative nodule in the rectum. The path was positive for moderately differentiated squamous cell, P16 positive. The left inguinal node was biopsied. I had an asp, but they had done it before I saw her, showing squamous cell. She didn't have any other metastatic disease outside of the pelvis, and I'll show you her PET. She was HIV negative, and GYN exam showed no invasion of vagina, only abutment. She was COVID negative prior to starting. There's a twist here coming you can think of. And her pregnancy test was negative. And she was counseled on ovarian function and infertility risks, but opted not to have ovarian transposition, which means pulling the ovaries outside of the radiation field. So here's her PET. She had, I'm just showing you 2 slices, but she had a 6 cm anal rectal mass. You can actually see the nice chunky left inguinal node and then the right inguinal node. And then she had a small upper lymph node sort of approaching the pre-sacral area, and there was no distant mets. So on her AJCC staging, she was an HPV positive, HIV negative, locally advanced anal cancer, and she would be a T3N1A. And again, N1A is mets in the inguinal, mesorectal, or internal iliac nodes. So for treatment, chemoradiation. She wasn't interested, as I mentioned, in fertility or endocrine preservation. And she had IMRT, and I'll show you that in a second, 54 gray of the primary and the chunky inguinal nodes, and 50.4 of the smaller nodes, and 45 gray to the elective nodes. She's got week 1 mitomycin and 5-FU, but then she developed symptomatic COVID at the beginning of week 4, and myself and the medical oncologist decided to put her on capecitabine, and we delayed giving her that second bolus of mito until her symptoms resolved. I do cone beam CTs every day for the radiation oncologist. For the non, we actually can do a CT on our treatment machines. I did notice the disease was shrinking. She still had some, I would say that left node was still chunky, so we really wanted to get that second cycle of mito in. Her hematologic profile remained pretty good. This is what I do for planning. I do most of my patients prone. I find I can still get more bowel despite the IMRT out of the high radiation dose. I put them on a belly board, which is a device where your belly kind of falls through an open hole, and that's how we get the bowel out of the way. I give them a full bladder to also push bowel out of the way. I do give oral contrast so that I can see the small bowel when I'm doing my planning. I don't really use IV because I just fuse the PET and their CT when I do my planning. I always put an anal marker at the verge, and if there's disease outside of the verge, I'll mark that with wire. I don't use a vaginal marker. I actually think that can push things around and make me have to use sort of wider margins for my planning. Small CT thickness for when I obtain my planning CT. And again, I actually do a full VMAT IMRT now. So just to show you one of her slices, when we do the planning, I actually take my anal canal and my GTV fusing the PET and what I do for digital rectal exam. And then I add 1 to 1.5 cm to that for my CTV. I trim it off of the red right here is the CTV off of muscle. I actually do, if there's no, in this case, uterus for men, prostate in between, give a little wiggle room into the full bladder. And then I add 5 millimeters for my PTV 54 for that. And similarly with the groins, for the nodes, I typically just add 7 millimeters to a CM, depending on how far the skin's away from my CTV, and then an additional 5 millimeters for my PTV. If they're elective nodes, I'll take the vessels and do a 7 millimeter expansion, obviously not in bone or muscle. And these are straight off of the 0529 constraints. It's often hard to meet the small bowel and even the bladder, but I definitely meet the other constraints. And this is this person's plan. I actually usually try to do a 270 VMAT. I carve out a little pie slice here to avoid the genitalia, but her bulky nodes made me want to do sort of a full arc. We use 6MV. I told you about the doses, and unless there's disease outside of the verge, I don't use bolus, but I'll do a diode or a TLD for 3 days by placing one of those over the verge, whether I have bolus or not, to kind of measure that dose to get some confidence about, you know, how much I'm giving there. And I just mentioned I do daily cone beam CTs. This is hers, pretty good image. And this way I can make sure I get coverage exactly how I planned on all levels of her plan. And I can actually see the disease response. So after I finish, I check every month for disease regression. And at 3 months, I try to get a PET. Sometimes they pay, sometimes they don't. And I'll have the surgeon do an anorectal scope. I find that 3 month is still a good marker, but if the disease is still there at 3 months, I would wait to 6 to sort of render an opinion on whether we need to consider an APR at that time. I don't ever have the surgeon biopsy unless it's progressing or at 6 months there's still disease. And in this case, I just saw her yesterday, nope, I lied, Tuesday for her 3 month. She's looking good. And then I make sure I give, even though I don't really see stenosis too much with IMRT or at all, I still give my pelvic radiation females a vaginal dilator at their 1 month follow-up. And I have to say, they don't often use it. She wasn't using it too much. So in summary, multidisciplinary treatment is imperative. We always work with our surgical and medical oncology and radiology and pathology colleagues to develop our treatment plan. We actually had our tumor board at 6:45 this morning. Our surgeons tend to have to go to the OR at 7:30 on Fridays. I think chemoradiation with curative intent still is the gold standard for untreated localized patients. In the States, we still mostly use 5-FU and mitomycin, although sometimes we, based on a 20 patient pilot series, use capecitabine, just like we use it for rectal cancer with the mitomycin. IMRT is now standard. Adjuvant chemo and EGFR inhibitors were shown to be ineffective. And I showed you our just recently closed study looking at adjuvant immune modulation, as well as the currently ongoing study looking at de-escalation for early disease. So are we moving the field forward? Slowly, but yes. I want to thank you so much for your attention. I look forward to questions on the panel. And this also was from Tuesday. I had a lot of Tuesdays this week. We actually had a smallish department dinner in sort of COVID social distancing style, but then afterwards went to the highest outdoor sky deck in New York City called The Edge. And that's a virtual picture from it, even though real, placed in what it looks like to look at this beautiful city that I now live in, and just one of my iPhone pictures I snapped while I was out there. So thank you very much.
Thank you, Dr. Kachnic, for your in-depth lecture. I believe that our audience probably have a lot of questions to ask Dr. Kachnic. We will do Q&A in the panel discussion session, the end of all the speakers. Now let's move on to the next speaker, Dr. Nora Tanner